morning, everyone. It's 10:30, so I'd like to get this webinar started. My name is Diane Cresswell. I work with BioNow, and BioNow is a partner on the Atlantic KET project, which is a project funded by the Interreg Atlantic area in the EU, and it's to support key enabling technologies in biomedical product development. So this webinar on health economics is one of a series of webinars to basically train people in the sector to share experiences as part of the project deliverables. I'm really pleased to welcome Dr. Ian Jacob, who's a Senior Manager at Health Economics and Outcomes Research, and he will be presenting the slides and the discussion today. We've got an in-room audience. If you have any questions, if you could just please wait for the question break. For people online, that's great. Just type your question in. You should have a panel there, and we will ask the questions on your behalf as the webinar proceeds to suit our sort of timings. One last thing, the webinar will be recorded, so it will be available to view afterwards, and the link will be made available to you. So without further ado, I would like to introduce Ian Jacob, and we'll get the webinar started. Thank you.
Good morning, guys. And yeah, thanks for the introduction, Diane. And it's quite a pleasure to be here to present today on health economics. Just a little bit of an introduction to myself. So I'm a senior manager of health economics at a consultancy organization called Health Economics and Outcomes Research Limited. We do exactly what it says on your tin. So we're a full service consultancy company. We're frequently asked to advise and conduct research on behalf of SMEs, so small and medium enterprises that are involved in developing technologies for the healthcare industry. So we've got a vast experience in terms of advising and conducting research on its behalf. So I'll just skip straight into in terms of the aim for this workshop. So when I originally spoke with Diane, what we really wanted to do was make sure that this workshop was interactive, but also useful for all of the attendees, both in the room here and those joining online. So it is meant to be an interactive workshop. If you do have any questions at any point, please do just raise your hand, or for the online guys, just to type them. I'm happy to take them as we go through the webinar. That's certainly not a problem. So in terms of today, what we really wanted to do was give you an introduction to the key concepts in health economics and how they might be applied in your research. We wanted to give you some practical, real-world examples in terms of how health economics research has been used to support both the development, the reimbursement, pricing, and market access for devices and medical technologies. And of course, we were happy to answer any and all questions. So, what is health economics? What is economics? It's not rocket science, luckily. So, in a sense, economics can be conceptualized in terms of three concepts. So here we talk about scarcity, choice, and budget constraint. So economists are acutely aware that resources are not infinite. And whether that's resources in relation to the natural environment, like forests or water, or whether that's resources in relation to the labor force, the number of doctors that we have, or the number of surgeries that we can conduct, there is a scarcity in terms of the number of resources. We also know, in terms of economics, there's also an element of choice, and essentially, economists want to understand how both individuals and institutions make choices in relation to the scarcity of the resources that are available to them. And then finally, the last concept is a budget constraint. So everybody has a budget. Again, we don't have infinite amounts of resources. If we did, that would be a nice scenario, but unfortunately we don't. So given all of these three concepts, economists want to understand that given a budget constraint, so for example, we can say the NHS here in the UK has a budget constraint. It's allocated by the UK Department of Health. It needs to make choices. And those choices are made in the context of scarcity of those resources. And essentially, any company, any organization that's operating within the healthcare sector is again facing these three concepts. So either who you're trying to sell into has a budget constraint, perhaps you have a budget constraint on yourself in terms of the amount of research that you conduct, and there's always amount of choice. So your product will be in competition with another product, maybe in competition with competing ideas. And really what you want to get out of this session is, how can I use the concepts and the methodology of health economics in order to improve my chances of gaining market access and hopefully reimbursement for your product. Then in terms of the next slide, so in terms of is healthcare economically important? Well, of course it is. So healthcare expenditure in the US, for example, it's above 1 trillion in 1997. That's way higher now. It accounts for potentially over 15% of GDP. This will vary from country to country, but even within the European Union, the healthcare expenditure, whether that's regardless of the type of healthcare system, whether it's insurance-based or publicly tax-funded, it does take a significant proportion in terms of the GDP of a country, and this is only going to grow. Okay, so we know that expenditure on healthcare, both public and private, is set to continue to grow into the future. In terms of the UK, so it comprises about 17% of all government spending, and it's a major consideration in terms of the fiscal management of the economy. So changes within the healthcare system can have massive consequences economy-wide. And it's really important then that governments, have pay specific attention in terms of how that money is spent, how well that money is spent. And all of that 17%, say, in the UK, has essentially a choice there. Okay, so we want to be able to allocate that 17% most efficiently so that we can maximize our potential gains. In every developed economy, so I can't emphasize this enough, it is economically important. It's a component of spending, investment, and indeed employment. The NHS here is one of the largest organizations, one of the largest employer organizations within the world. And then in terms of the economic performance, so we know that there is a link between a good functioning healthcare system in relation to the overall economy. So it is incredibly important to the economy. Then just looking again at UK spending. So apologies, some of my numbers in terms of spend are a little bit out of date, but I just wanted to give you a feel for the trend. So this just goes up to 2011, but you can see again, public expenditure here in the UK has been increasing year on year. We have seen more recently a little bit of a dip when we come to the economic crisis more recently. However, the public expenditure has tended just to flatten out, and now we see it tending to grow again. Private expenditure on healthcare here in the UK, again, that has tended to grow, but not by a significant amount in terms of public expenditure, and that's just due to the nature of the healthcare market here in the UK. So we know that public-private provision and out-of-pocket payments for healthcare services here in the UK tend to be quite significantly lower than public expenditure. It may differ in terms of some of the systems within the European Union. So then in terms of, okay, so it's important, healthcare is important. We spend a lot of money on healthcare. Why is it important to me? Why are economists interested in that? Oh, well, it's the age-old problem. So we have decreasing healthcare budgets, potentially. So we have seen this in recent years, although this is in line with kind of the cyclical nature of the economy. And even if the healthcare budgets weren't decreasing, they tend to remain flat for the most part, particularly public expenditure. But we do know that the costs of new drugs, new diagnostics, new medical devices, they are increasing. It costs a lot of money to develop a new device. I'm sure you know that yourself. And the competition for these has grown. So not only do we have significant private investment in terms of the development of these, but we are also trying to understand our competitor base and in relation to decreasing healthcare budgets. So how can we justify the research and development outlay in terms of a flat space or a decreasing space in terms of healthcare budgets? So health economics is needed to inform decision makers on which products essentially to reimburse or support, and with the aim, so their decision aim is to maximize population health. So economics provides decision makers with essentially a framework for which they can evaluate, and I'm going to say potentially solve this problem in relation to flat or decreasing healthcare budgets, but yet increasing costs of new medical devices, new medical drugs over time. Okay, so moving on to key concepts in health economics. So we understand now health economics is incredibly important. Now we want to just understand, in terms of the key concepts, how potentially that they can inform your research and your commercial development. So in terms of framing that decision making for healthcare, say, commissioners, so we can judge the use of healthcare resources in terms of efficiency. So you'll hear concepts of efficiency used widely across all of the economy. Okay, we are fixated on having an incredibly efficient economy, whether that's in terms of the labor force or whether that's in terms of the production of cars, for example. But we tend to be obsessed with maximizing efficiency, and this is even in the context of the NHS. So you'll often hear in terms of headlines in the newspapers here in the UK about elements of waste within the healthcare system, whether that's how we allocate appointments in GP services, how potentially we organize surgeries. So we want to understand that, you know, we have a fixed set of resources that we can use, and we definitely want maximum value, so the most efficient allocation of those. So essentially, we're maximizing our output in this context. So we can judge healthcare resources in terms of how efficiently we've allocated those. We can also look at effectiveness. So this is the extent to which healthcare services actually improve health. So they could, not only are they efficient, but now they're also effective. Okay, so here we're talking about the evidence base that demonstrates that the new drug, the new medical device is effective in what it aims to do, which should ultimately be to improve the health of a particular group of patients or as a population on its whole. This is also a regulatory hurdle in addition to a health economics hurdle. So you often hear, certainly in terms of the pharma world, of the four hurdles to market access. The regulatory hurdle coming before the reimbursement or the health economics hurdle. So clearly, you need a way of demonstrating that it is that the drug or the device is efficacious. We can also look at it in terms of equity. So that's the fairness in terms of sharing resources between individuals. I'll say in terms of my own research program, equity doesn't really feature in that. However, it is a quite a large area in terms of health economics, and really what those economists want to understand, or how they evaluate that problem, is just in terms of, after we've allocated the resources, is that a fair allocation? So who gets what? Is it the case that you know, everyone has a fixed expenditure, so everybody gets, say, £10,000 per year to spend on healthcare, regardless of whether you're sick or not, regardless of whether you have a current diagnosis or not? It could be considered fair. Yeah, everybody gets the same amount. There's no picking or choosing. However, it could leave some individuals who seek to purchase healthcare, for example, because they have a cancer diagnosis, out of pocket, while others who don't necessarily need any medical attention, maybe they want to spend it on shall we say, more cosmetic healthcare expenditure, liposuction, for example. Is that fair? Well, everybody gets the same amount, so it could be considered fair. There are other concepts in terms of equity that would look to distribute the resources in relation to those based on need. Here in the UK, for example, access to medical services is essentially based on your needs. So there are no out-of-pocket expenditure for those individuals. And then consumption is based on your need for that consumption. So healthier individuals will consume less from the healthcare system as those individuals who are unfortunate enough to be ill. And then finally, there's also an ethical component. So I guess when I started working in economics, I was always, I guess it's a constant kind of critique that we're not really concerned about the ethics, right? We're really only concerned about budgets, maximizing expenditure. That's not the case, certainly not the case in health economics. It's quite, as an area, we tend to collaborate quite widely, probably more widely than what our more traditional economics, macroeconomists would be. So we tend to collaborate a lot with ethicists, those that are involved in equity, those are involved in psychology. We collaborate quite widely, and because of that, we've been able to draw on many different methodologies. So ethics is still quite an important area in terms of healthcare resource. Having said that, so this is potentially how we judge. How we could judge that problem in terms of how we allocate the scarce budget for healthcare. We tend to focus on health economics, certainly I do, and I think what would be more useful for you is in terms of the first two elements, so efficiency and effectiveness. So those are things, and I think it would be very rare, if ever, you would have to address any issues in relation to equity or ethics, even though you might want to discuss those. And just outlining a map. So this I've borrowed from an original publication in Health Economics that aimed to kind of put a landscape in terms of how broad the area of health economics is. So you can see here in terms of the core areas developed. So the meaning, measurement, and valuation of health is one. Influences on demand. Economic evaluation, which is my area, which is quite a major component of health economics, but it can also be much broader than that in terms of looking at market equilibrium structures, particularly in relation to non-competitive markets, so those with monopoly powers. There's a whole body of work that goes into understanding planning, budgeting, regulation, and indeed whole system evaluation. The majority of times when we talk about the typical health economics headline in a paper, really we're talking about economic evaluation here, which aims to inform decision making in terms of what products and services within the healthcare system are considered value for money, are considered affordable, and therefore reimbursed within a healthcare system. So the majority of, I think, your interest should be in the area of economic evaluation, but that may not be the case. You may want to look or consider other areas, and it is a huge space. Okay, so now that I've talked about the principles of economic evaluation, and I should say, if you do have any questions, please do just raise your hand. I'm happy to take them at any point, including from those that are joining us online. But now just to move onto some of the principles of economic evaluation. So in a sense here, what we want to do is understand the costs and benefits. So again, like I said, health economics, not necessarily rocket science, although some of the math might be complicated. We can distill this evaluation framework in terms of the costs and benefits. So we need to be able to recognize that there are costs incurred, there are total costs incurred from any intervention, any technology, and there are potential benefits. And we want a system that we can weigh those off. So are the benefits, are they worth the cost outlay? What we compare those costs and benefits to. So this economic evaluation provides us with a framework for us to do that. And again, so the key question here is, how do we determine value for money? And I'll probably add on to that statement. How do we determine value for money and affordability within a healthcare system? So essentially, this is a question that you will ask. And it's a question that's often leveled at companies at all levels in terms of the healthcare system. So when we look at national level evaluation, for example, here from the National Institute for Health and Care Excellence, essentially, what they want to understand is at a population level, does your technology demonstrate value for money? But even when you're sitting down, say with a hospital purchasing department, for example, they'll also want to understand, is this value for money? Okay. The economic evaluation framework is also underpinned by this idea that economics has been using for quite some time. This idea about opportunity cost, and it's also related to perspective. So here we understand that whatever choice that you make in terms of whether that's to purchase. So say, for example, if we bring it back to maybe a consumption problem in terms of what you might face every day. So we go down to the coffee shop, we purchase a coffee, and we're also purchasing probably, let's say, a chocolate bar to accompany those. You have a choice there. The budget, luckily, I don't think it will break the bank. However, you are making a choice there. So you're choosing, say, for example, you choose a Mars bar over a Snickers bar. You are making a choice, and the opportunity cost of choosing a Snickers is that Mars bar. So you could have equally have had the Mars bar. And from both of those, you get a benefit. And let's say that benefit is in, say, reducing your hunger or satisfying that sweet tooth. The benefits from the Mars bar, for example, could have been better, for example. So you could have had, maybe it's a better bar in terms of its outcome, so it just satisfies that hunger a little bit more. That's the opportunity cost of your choice for choosing a Snickers bar instead. And that is the prevailing understanding of how individuals, how economists understand individuals and try to quantify this. So we want to understand not only the implications of the choice that you have made, but the implications of the alternative choices that you could have made. And by framing the context in that, then we understand whether it is actually true value for money. So we want to understand the alternative uses of that and the value of those alternative uses. So here, I guess, the opportunity cost in terms of healthcare can be best measured by the health benefits. And I've just introduced a concept here you may not be familiar with, and this is the idea of quality-adjusted life years. So this is essentially the additional life years that you've gained in addition to the quality of those life years that you've gained. And the opportunity cost is, if I chose an alternative technology, so an alternative medical device, would have the life years, or would the quality have been better or worse or the same than the alternative choices, than the product that you've developed? And this is kind of the core of the understanding of what we want to understand when it comes to understanding alternative interventions and their relative value for money. We'll come on to the concept of QALY later, and we'll walk through how you might want to measure that and use that in your evaluation. So then, in terms of perspective, so it's important to understand that the perspective that you might have may be different from the decision maker's perspective, whether that's national level decision making or local level decision making within the hospital. But you're conducting your analysis on the basis of your target perspective for that individual. So here in the UK, for example, the NICE reference case mandates that we should look, in terms of the study perspective, should look at the direct costs, so the costs incurred by the NHS, and personal and social services costs. So, for example, what NICE will not include are the perspectives potentially from, let's say, the patient. So what's important from the patient perspective? It could be out-of-pocket costs that are incurred. They're typically not incurred in they're typically not evaluated in economic evaluations for national level decision making. Or potentially, the most broad of all is societal perspective. So moving from the perspective of the national healthcare system, so the costs and benefits occurred within those, broadening your perspective out to societal could, for example, include intersectoral costs and benefits that are associated with your technology. So, for example, if your technology helps individuals get back to work quicker, or it reduces the level of absenteeism in the workforce, that is a definite benefit for the economy as a whole. Typically, though, that's not included within the say the more narrower healthcare service system perspective. The healthcare system doesn't benefit really if it means that individuals, say, get an average of 10 days more in work per year because of your technology. But it certainly benefits in relation to the economy as a whole, and it may be that that this is one of the key benefits of your technology. In which case, a careful consideration of the perspective, even if it's not directly mandated by your national healthcare authorities, might help in terms of the overall value messaging that you might want to put together in terms of that value story for your product. Okay, so just I guess putting together a little bit of an example, just to make it a little bit interactive this morning. So in terms of opportunity cost, so let's set up a scenario. Here we have a single course of IVF that costs £2,700. And what's the opportunity cost of that? So let's say that I choose to invest in this course of IVF. It's actually an active area of research for me and my company at the moment. Well, within the healthcare sector, so let's say over here on the right-hand column, so these will be kind of considered the opportunity costs within the healthcare system, so using the healthcare perspective. So here that would be in the UK, the NHS. So what I've forgone, if I choose to invest in the IVF technology, I could have forgone potentially a third of a cochlear implant, so they're quite expensive, or potentially 150 vaccinations for measles, mumps, and rubella, 11 cataract removals, or 1 heart bypass operation. Those are the opportunity costs that are associated with my choice, or let's say a decision maker's choice, to invest in IVF technology. Of course, the key question then is that, does that demonstrate good value for money? What would help me make that choice? So clearly I need to understand, okay, so these are my potential options. So heart bypass operation, you know, if you don't have your operation, mortality, I guess, will not be very pleasant. But it's only for one person. What about the 11 cataract removals? Okay, this affects your sight. So for example, because I've chosen to invest in IVF, it means that 11 individuals potentially risk worsening eyesight. That's quite but in a sense, these are the decisions that any healthcare system, in the context, if we go back to our original core concepts of economics, so that's scarcity of resources. So we don't have unlimited resources. We can't fund all of these. And we do have a budget constraint, okay? So our budget here is 2,700. That's all we have. We can't spend more than that. And we have a choice. We have a choice here. If we broaden that perspective out, for example, if it's, let's say we have intersectoral budgets, so budgets that don't span specific silos in terms of health, education, defense, social care, for example. Perhaps the opportunity cost is half a junior school teaching assistant for a year. That seems a little bit incredibly good value for money for me in 2,700, but there we go. 2,000 school dinners, or 1,000 of a Challenger 2 military tank. Now, I'm not very familiar with defense technology, but I wonder what we do if we didn't have the rest of the tank. Maybe it's not so efficient. But again, these are essentially the opportunity costs. And I guess the key question here is what we haven't understood. We may have understood the costs of these. Really what we haven't understood in this slide is the potential benefits. So we need to understand the benefits in order for us to make an informed decision for how we allocate that resource. Okay. So a little bit of a game, again, keeping it interactive this morning. So would you prefer to receive £1,000 now or £1,000 in 10 years? So I guarantee you I'll be back here on this spot 10 years' time. I'll have £1,000 in cash, and I'll be happy to give it to you. Or perhaps I'll also receive, well, let's say I've got £1,000 in my bag, shall I say. Would you prefer to receive that now? Well, good. So the majority of individuals, the vast majority of individuals, would prefer to receive £1,000 now, for sure, rather than wait 10 years in the future to receive £1,000. And this, I suppose, is just kind of a faux demonstration of in a sense that individuals discount costs and benefits at a rate. So generally, individuals prefer to receive a benefit now, but prefer to offset the cost, or prefer to have the costs incurred in the future. So all evaluations, or most evaluations, I would say, will have an element of discounting involved. And this can be important, particularly when your product, your medical device, perhaps it's really expensive up front, but the benefits are not incurred until maybe 10 years' time. So we're particularly thinking about preventative technology here, so preventing, say, future strokes or preventing future heart attacks. So discounting can have a huge impact in terms of the economic evaluation. The concept of discounting is not confined to health economics. In fact, Her Majesty's Treasury Green Book, so this is the Bible for evaluating public investment in the UK, specifies what the discount rate should be for any investment made in relation to the cost of that investment and the expected benefits of that investment over potentially the lifetime of that project. So in some instances, we do see, and I know in terms of the French perspective, so I can't remember what the name of the French guidelines are, or the French government guidelines are, but for example, they'll also have a similar framework in terms of discounting to evaluate public investment in say, roads, airports, hospitals, for example. But it's really important that that's considered in terms of your economic evaluation. Essentially, what we use discounting so that all costs and all benefits are transformed into what we call net present value. So we understand the value will be different in the future, but we want to be able to make a fair assessment between how those costs and benefits are allocated over time. So that's called present value. So yeah, most individuals will prefer to receive £1,000 now, and I'm glad you guys are conforming to the norm. Okay, next slide. Okay, so in terms of so I spoke earlier just a little bit in terms of the question. So what determines value for money? And I also kind of tagged onto that question. Not only is it good value for money, but is it affordable to healthcare system? So economic evaluation it can be broken down really roughly in terms of two kind of components, or two kind of, let's say, evaluation paradigms. So here, cost effectiveness analysis, and it's clearly written here, determines whether an intervention is good value for money. Okay, so it compares that value of one treatment versus potentially multiple other treatments that a physician and a patient could be faced with. And then it's going to answer the question, is that good value for money? So the relative cost difference between so let's say you have two comparators, so your new medical device, which has a certain cost. Perhaps it's more expensive than the current standard of care medical device that's used in the healthcare system. Let's say it's £100 more expensive than that. But we also understand that it generates potentially, let's say your medical device improves the diagnostic accuracy on the current medical device that's used in that. So we have a clear benefit here. Maybe you've used, maybe you have demonstrated that efficacy in terms of a trial, or you've used observational evidence and then you've incorporated that into an economic model. So you know that you get additional benefits. So let's just say that you increase the number of diagnoses, number of, say, true diagnoses by 10%. And then let's just say that results in an increase in, say, 10 life years for a population of, let's say, 1,000 individuals. So that's your benefit. So you get, essentially what we want to understand is that worth paying for in relation to the current standard of care? And that's where cost effectiveness framework will help understand that. But that's not the only framework. So the other one the other paradigm is what we've stated here is budget impact. Usually these are presented together. So here in the UK, the National Institute for Health and Care Excellence will evaluate firstly whether it's good value for money, and then secondly whether it's affordable. So if, for example, we chose to reimburse your new medical device, well, we know that it's good value for money. So on average, we're going to have 10 additional life years for a cost of, let's say, an extra £100, which is incredibly good value for money. But is that affordable? So the budget impact here will calculate the additional expenditures, the fiscal impact of introducing your new technology on the healthcare system as a whole. So in a sense, it assesses whether the healthcare system can afford that. And the key difference here is that the cost effectiveness framework, it's kind of agnostic to, say, the prevalence or the incidence of the underlying condition. So we're not really interested in kind of the total cost of those. What we're interested in is the relative benefit and the relative cost. So it's agnostic to the underlying epidemiology. Whereas the budget impact models, for example, will include the underlying epidemiology of the particular indication. So whether that's let's say, for example, if it's a genetic disease or potential number of strokes, potential number of heart attacks. What the budget impact model will do, we'll take its, in a sense, the population view, and we'll estimate what the increase of that budget will be, and then that will enable then decision makers to decide whether it's potentially affordable to the healthcare system. So those are the two, I suppose, kind of, obviously cost effectiveness research can be broken down, and we'll go through some of these in some of the subsequent slides. And the methodologies for these will differ a little, as I explained, in terms of including epidemiology or not. And indeed, the data that's used to support both of these frameworks will be slightly different. As I said, any questions, please do ask. Okay, just as a little bit of a live example in terms of the budget impacts analysis and in a sense demonstrating that in relation to perspective. So here, with my little Lego figures, I've set up essentially the perspective. If we go from right down to left, this in a sense represents us widening the perspective. So for example, if we're just interested in healthcare sector as we are in the UK, then we're only really considering the costs in relation to medication, GP, hospital visits. We're not necessarily interested in some of the societal costs that could, say, for example, that are incurred outside of the healthcare system. So here in the UK, for example, social services, so community support for the elderly, for example, that budget falls under a local authority rather than an NHS budget. So here we'll exclude that. And then patient out-of-pockets and lost productivity, again, widening those perspectives. Your perspective here can determine essentially whether you're in the budget impact framework, whether it's affordable or not, depending on the scope of costs that we'd include. So here you can see that your technology results, it's more costly here. So we've increased our medication costs, we've increased our GP costs, we reduced our hospitalizations, which is potentially a good thing. But actually, overall, what we've done is we've increased the healthcare budget by €400 in this example. So it is more costly. So those are the total healthcare costs. However, when we broaden that out, when we broaden out the perspective, so now we include community rehabilitation. It's reducing the costs for community rehab. It's also reduced the out-of-pocket expenditure incurred by patients. From a patient perspective, that's incredibly important, in addition to the efficacy of the technology. And we've also reduced the lost productivity to the healthcare system. So for the UK, for example, that's incredibly important, right? We're often accused and in competition with our European colleagues of not being as productive of some of the other European nations. So as a government policy, that's quite an achievement. As a healthcare policy, well, it doesn't matter. It doesn't affect anything in terms of the NHS. It doesn't improve their budgets. It doesn't improve their fiscal situation. However, what you can see is as we've increased the perspective, now we've gone from a situation where your technology is more, say, has an increase in that budget, and now it's cost saving. So you can see that understanding the perspective of which you're conducting, and this can equally be applied to cost effectiveness framework, but understanding that perspective is incredibly important. They want costs later and the benefits now. And we use that then as a framework to design our cost effectiveness analysis. So it wouldn't necessarily be a fair a statement to say that the NHS makes decision-making on costs in the future and benefits now, because you're right, that may not be sustainable. That's not necessarily how decision-making is done in a healthcare system. But it is really important to understand that when we want to ascertain what the value for money is, that we understand that those costs and benefits that occur in the future need to be discounted at a sufficient rate, so that when it comes to evaluating a preventative program, so for example, reducing obesity, so say for example, you have a childcare intervention, and I got to spend a lot of money now, but the benefits I won't see until 20 years' time for this cohort of kids. If I don't discount those benefits and the costs at sufficient rates, you'll have at appropriate rates. So for example, we are allowed to have differential discounting rates for the benefits and now. Then I may not be making a fair reflection in terms of decision-making for an economic valuation, as opposed to, say, purchasing drugs for diabetes now, and the benefits are probably further. So what that does, it allows me to make a comparison between a preventative program where the benefits are much in the future, if I can apply differential discounting rates. So I understand that the rates may not be the same between those and a program that I can invest in now. So it allows a fair comparison to what you say would be more. But we don't see that happening a lot. So we don't see really what we're only concerned is essentially what we see is there is a separate budget for preventative programs, and they're evaluated in their own sphere, as opposed to programs that will be for drugs, for example. But that's not to say that in your evaluation of a preventative program that you shouldn't be interested to say, okay, so if you can demonstrate that it's effective, so it reduces obesity, then you'll be able to calculate the drug use avoided for, say, the diabetic use. You should be able to estimate what the potential reduction is in terms of limb amputation is. So those all costs would be included in your preventive programs, and obviously a pharma program probably wouldn't be able to demonstrate those types of benefits, all resting on your evidence base.
I have a question from an online.
Great.
Can I ask which markets look at patient cost and lost productivity? I haven't seen this model in the UK market.
It's not in the UK market. So which markets? Okay, I'm going to correct my statement. So not in the UK market, potentially. In the area of IVF, which I'm currently working in, we are interested, and it's the evaluation of IVF therapies would occur outside of the National Institute for Health Care Excellence, for example. So, for example, if it looks at vaccines, for example, that's evaluated in a different framework. Indeed, the screening programs are evaluated in a different framework, so breast cancer screening, for example, and those will have perspectives that will potentially be wider. But typically, the majority of stuff that we see will be stuff that will be coming from the National Institute for Health and Care Excellence, and yeah, you're correct, the perspective doesn't include productivity costs. However, that hasn't stopped companies making arguments to that effect. Yeah. In terms of Europe, it's varied, but I would say the majority of that is, as the question suggests, it's mostly total healthcare costs.
If I do revert to the IVF,
yeah.
This model favors IVF over any of the other treatments because you create a new human being
yeah.
with the lifetime productivity.
Yeah, absolutely.
So why is there any discussion?
Yeah, no, and you're right, and that's, but again, it comes back to the opportunity cost. So for example, in IVF, it's a really interesting one in the sense that you're right, I create a new life, so my life years, should they include the life years of the child or not, so of the new baby, and there will be a probability of success, and then I'll have to make some assumption in terms of quality adjusting those, so that child will be subject to diseases potentially in the future. So am I going to model those out or not? And then again, there are productivity gains from that additional child. So you're right. If I was to say include productivity gains, yeah, you're right. There could potentially be, if I take the average industrial salary for a potential individual and I'd say they could achieve this much, then yeah, there is no, but what you would end up doing is spending a lot of money on IVF and maybe not so much money on heart bypass. So again, the solution typically seems to be that IVF is taken, in terms of the UK's perspective, decision-making in IVF is outside of what would be a standard framework for, say, diagnostic technology. So we wouldn't be considering it in the same budget's envelope as, say, a genetic test, for example.
Is there an element of choice when it comes into your analysis? So, for example, IVF is an opt-in, whereas a heart bypass is a take it or leave it,
Yep.
and you die. So whereas you're saying there is an opt-in value gain,
Yeah.
a no action cost would be zero for
Yeah.
IVF.
Whereas
a no action cost is very different for an emergency or an essential treatment.
Yeah, no, absolutely, and that could be it. So if we have the data to suggest that, and if I set up my decision-making framework that I wanted to understand, if I wanted to invest in either the IVF technology or the cabbage, for example, then if I have evidence to support what the choice looks like, I would include that in my economic evaluation for sure. Yeah, absolutely. I'll just maybe, I'm just going to run through in terms of, because you bring up the question of choice, and it's a really good one. And this will help solidify in terms of what the cost effectiveness framework looks like as opposed to the budget impact framework. Essentially, I do have a choice here. The choice essentially will be between several options. So what, in terms of your, say, your diagnostic device, for example, or your medical device, you're not going to have all the choices in the NHS to include here. So you're going to have a limited amount of choices. So identifying what those comparators will be to your technology are important. So we've talked, in terms of all the examples that I provided, the difference between IVF and, say, a tank, those are all conceptual things. So in terms of the actual realities, you'll be asked to evaluate your technology in relation to what its competitors, what its comparators are. So you should be able to understand, and this is really important, so this is often missing from grant applications, is a description of the comparator technologies that your new technologies is expected to compete with, and understanding the evidence base of those. So I see a lot of times in applications, I see really good descriptions of technologies. I'm not an expert in the field, I'm a grant evaluator. I have no idea what the other technologies are. And in fact, if there were none, that would be really important, because that's a clear unmet need. But if there are many, if there are 10, I would also want to understand that and understand what your expected benefits are. So understanding what the options are is incredibly important. So typically, the options will not be a preventative program versus, say, a therapeutic program, but there will be the different therapy options, or there'll be the different preventative options within there. Each one of these will have an associated cost base, and they'll also have an associated benefits. You can see here that I'm setting this up as a ratio between these. You can have as many options as you want, but they're all still in terms of their costs and benefits for each of these. And then we make a decision across those. Okay, so we've talked a lot about the costs, and I think costs are, they're a monetary value, really easy to understand. It's pounds, it's euros, it's dollars. Benefits in healthcare, not so easy. In terms of what you see quite frequently, and this is going to be the main challenge for any medical device, and I say this because it is a challenge for pharmaceutical therapies, but they're luckily in the sense that they will have instruments to measure these. Typically, most medical devices find the greatest challenge is to measure the benefits in terms of this concept here, which is quality adjusted life year, so QALYs. So you'll often see this being used. You'll probably see this being reported, but essentially a QALY is a generic measure of health for an individual. It includes concepts of the quality of that life and also the quantity of the life. So it includes both of those. In economic evaluation then, that allows us, so for example, if I've got 10 options, and most clinical trials will have different endpoints for those. Some of those could be, for example, reduction in lipids. Some of those could be reduction in the number of hospitalizations. But I want to be able to compare between those, so I need a common measure, and that will be the quality adjusted life year. One QALY then equates to 1 year in perfect health. And I'll just demonstrate what that looks like in terms of an intervention. So here we have two options, A and B. In terms of option A, so that's without the intervention, I have so many years in terms of time to death. The new intervention will increase that. So luckily, I have, it'll delay my average time to death. So that's really good. So that's one element where my new intervention is improved. But as you can see here, it also improves the health-related quality of life. So the quality of life of that time has also improved for this technology. So you can see that without the intervention, it's about, say, shall we say that's 0.5. With the intervention, it remains quite high, so up towards, we'll say that's 0.9. And then you can see that that's maintained over time. So the gains in terms of quality of life are maintained. Your element of value, so what you'll consider good value for money, is essentially that shaded area for B there in yellow. So this is the gains that an individual has. And then if we scale that up, so we say the prevalence of this disease is 1,000 individuals in any one particular year, multiply that area by 1,000, gives you that gain to the healthcare system in its entirety. And this is what most economic evaluations are interested in, is measuring quality adjusted life years. Again, a real key challenge, because for a medical device, you'll need to understand, are there any mortality effects? And typically that can be really difficult. And maybe, so say, for example, if my diagnostic device improves, so it's more sensitive and it improves the number of true diagnoses, for example, then I'll need to make an assumption, because that's where you've got to, right? You're not going to do a clinical trial to say, okay, does that mean that I've reduced potentially whatever the implications of the disease? That mean I've reduced mortality, I've increased mortality, changed? And typically, most companies will not get up to observing individuals for that length of time. So you can see that's quite a key challenge in terms of mortality. And then health-related quality of life. Is it that you will measure that from an individual with or without a test? Is that the same over time? Can you measure that over time? You can see that's a real challenge for most medical device companies, yet the decision-making is still based on QALY. Yeah, and I say that with a caveat. So costs, I'll just briefly go through costs, because these are quite a simple, and you've got all the slides afterwards. So there are hospital costs. Essentially what I'm trying to understand here is that when you're considering costs, be as broad as you can. So that when you're starting off doing your grant application, when you're starting off doing your early development, just don't consider the cost of the device itself. That's irrelevant. I would say irrelevant, but really what you understand is the entire costs for that individual. So say, for example, if your device costs €100, that's fine, and you might understand that really well. But what most individuals, what most decision makers want to understand, how does that cost relate to the entire cost for an individual? So say, for example, that could be, per year, an individual cost should be 20,000, for example. In which case your cost is pretty minor. And then you're going to say, okay, well, what's the benefit that I get from that €100 if it's just adding? Or maybe your cost is offsetting other costs along the cost of your device is offsetting other costs along that for that patient, for example. So don't just consider the cost of your device, consider the cost of the therapeutic pathway for an individual for which you're developing your technology. There are lots of sources for costs here in the UK. And similarly, there will be similar costs for in other European areas that will be similar to these. I will send through some links after. So there's an organization called UNETA, EU-NET-HTA, that gives links to all national sources for costs. So the ones I've given here are just UK, but there are other ones that are available. Yeah, and we've given time, so I'll just go over these. So these are all examples of costs. Great. Measuring your value health gain. I've talked a bit, I want to give you some time for questions. I understand we've got about 5 minutes left. We talked a lot about quality of life before. There are, in terms of measuring what quality of life would look like, typically, this is done using a direct or an indirect preference-based method. So here, what I've given you an example is what we've called the EQ5D. So there is an organization that has developed a paper-based instrument that you can give to a patient, and that gives me a measure of health-related quality of life at that particular point in time. And in terms of getting to a single number, so typically we want that number to be on a scale of 0 being death, to 1 being perfect health. The instruments are designed, and they come with analysis package that enables you to give. So you would give this, say for example, this form has 1, 2, 3, 4, 5 levels. Each one of those domains has 3 levels within those. And based on that, and you can see that this one is looking at mobility, self-care, usual activities, pain, discomfort, anxiety, and depression. And based on that framework, we can measure the health-related quality of life of an individual at a particular point in time. I'm going to say no, I'm going to stand out on a limb here. 99% of medical device companies will not be measuring this health-related quality of life for individuals. So you'll need to understand what the potential impact is on health-related quality of life and understand that really well. Even if you don't understand what the impact is, but you understand what the potential impact could be in the lack of data, that would be really important both for a grant application and for subsequent economic evaluations. And then with some assumptions, then we would be able to potentially model what those might be. Okay, there are a lot of slides left, and I understand that we've got about 5 minutes left. Is that?
We can run over 5 minutes.
Run over 5 minutes, no problem. And what I might do is, if I give some examples, so this, and I do talk a lot, so apologies. These are all just referencing the quality of life measures, but I think if I do a little bit about healthcare markets, and then I can do a little bit about some applied examples, but any questions, please do stop me. So in terms of healthcare markets, so we've talked, so say for example what we've covered the basics of health economics now, so we understand how decisions are made. We understand the two main vehicles to understand what the economic evaluation will look like, so that's cost effectiveness analysis and then budget impact analysis. I've talked a little bit about the complications for medical devices around those. So just around in terms of healthcare markets, so typically the difference is that there's going to be a different payer here. So for most purchases, you have households who are in this case they're paying directly for healthcare providers to receive treatment. Very, very few systems operate like this, apart from maybe cosmetic surgery, for example. So cosmetic surgery, for example, isn't normally paid for by an insurance program or by the National Health Service, probably out of your pockets, in which case the market would look like this. The market could, or typically looks like there's a third-party payer. So in this case, this will be, so say for example in Germany, this will be your insurance, or in the UK here, it will be out of national taxation, but there is a third-party payer here. And it means that the route to reimbursement for your technology will be determined by what the financing framework based on the healthcare market will look like. So, for example, the requirements for insurance companies in Germany for an evidence base for medical technologies are vastly different to what would be required here in the UK, if you could say there was a framework here in the UK. It's important to understand. And then lastly, there is, in terms of the analysis for both budget impacts and cost effectiveness analysis. So here I have the terminology called model-based economic evaluation. And here, this is my primary area of work. So really what I do is, a lot of the work that I do, my team does, are build models. And those models will take data from various different sources. So for example, they'll take data from clinical effectiveness, they'll take data from disease progressions, quality adjusted life year and costs. They'll build a disease model, and this will be in Excel typically, and we'll model out so we'll take all of these data inputs over here on the left, and here they're represented by distributions. It's a bit technical. We have a model structure, so here it's just asymptomatic, progressive, and dead. And then what we'll do is we can take those data, and we'll come up with an estimate of the cost and quality for the interventions. That's essentially 99% of the work that I do, is building an evidence base to the left here, so understanding clinical effectiveness, disease progression, which is natural history, costs and qualities. We have very sophisticated techniques then, or very simple techniques, to model what the potential costs and qualities are. And then these are typically used then for arguments in relation to submissions for national reimbursement. It may look really complicated. The majority of the med tech models are really, really simple. So they will have very simple evidence bases, and they'll make very simple assumptions on what the potential impacts are. But I think at that stage, you'll have many different companies, including my own, that provide specialist advice in terms of what exactly the requirements you would need at that stage. My main take-home message from today, I think, would be to talk to an economist or talk to health economists. And we're really good at working kind of across different areas and across different diseases. So what I would say is either locally, from whatever country you will have, there will be a health economics consultancy that will be willing to engage. From a consultancy perspective, it does cost money essentially. But for those initial discussions, I think in most companies, they would gladly have those with you, including my own. So I'm going to leave it open to questions now. I know that was kind of a whistle tour at the end, but if there are any other questions that you have for me, please do shout out. Go for it.
So when you talk about the benefits and where they're realised, whether it's in a society or a different even department in a hospital, if say your device has more costs for a specific department within a hospital or trust, but the benefits aren't realised by that department, they're realised somewhere else. How do you kind of persuade someone who, from a procurement perspective, will be in that department to buy or adopt your device?
That's a really good question, and because typically the perspective here is like a local purchasing manager that's responsible, right? And they're not really interested in, and that's going to, so essentially you're stuck. So you still have to try and convince them that investment of, so it'll really be down to what their framework is for making decisions. So if you can convince them that the cost saving across other areas in the hospital, if they're in a position to make those arguments internally, to say, if I invest in this technology, the savings are over here, and potentially there's cross-budget envelopes, for example. But what you would want to be able to do is, because if they're going to make an argument, and I've spoken to purchasing managers before, but if they're going to make an argument to say that I'm saving in other envelopes, not my own, then they want to be really certain that they are saving in those, because there'll be other individuals responsible for those budgets. They'll go, oh yeah, okay, fine. If I'm going to give you some of my budget to pay for this device and I don't realize the savings, then I'm in responsible. So it's about providing a solid evidence base for that individual in order to make those kind of internal discussions. But again, that could be in the form of a model. It could be in the form of just something very simple in terms of the calculations. But that's really, really local level decision making. And essentially at that stage, there's no frameworks really. So it's the best that a lot of what we do here is kind of regional or national level decision making. So for example, CCGs would be very interested to understand about cross savings across those budgets. So go higher up could be one. If and CCG, sorry, just for those joining online, is a clinical commission group. So it would be considered a local area that's responsible for healthcare budgets. So for example, it could be the Greater Manchester Combined Authority. They could be interested in savings across hospitals within those regions, for example, if you can make that argument, provided that there's a framework. But all the frameworks locally may differ, so it's a challenge. Yes, sir.
Just following on from that, that's an interesting question, because when you're making a decision, obviously you look at the costs and benefits. One of the benefits that you may actually want to consider is how you get rewarded. That would affect some of my decision-making processes. So the key metrics, if I'm into key metric, quality of adjusted life, for instance, if that's a key metric for me and I get rewarded on producing that, then that may affect my decision. Are these weighted in some way, shape or form? Are they different across the...
That's a really interesting question. So essentially your decision-making framework in that, if you're incentivized to improve a particular KPI, if I haven't included that in my economic evaluation, there's no interest for you. But there's no national framework that operates in that fashion. So for example, I'm not the nicest in making decisions based on improving KPIs, other than the KPI of overall population health, as measured by QALYs. I would find I've never come across a situation where there's like local level decision making and I've had the argument say, okay, it doesn't affect any of my KPIs, but it could still save me money. I don't really want to engage. I've not come across that situation. I guess in that instance, my advice would be to, if you can, include, I'm kind of thinking just in terms of performance schemes, for example, and bonuses. Would we include those in economic evaluation at the local level? Probably not. I would say, I would go out on a limb and say 100% not. So, but then this is really local level decision making where it's really important to understand what the individuals are thinking in addition to the evidence base that you're producing. So, oh, good question. Sorry.
Ian, we've had a question online.
Great.
You talk about quality and quantity of life. Is there ever an economic argument based for just an improvement in quality without extension?
Yeah, absolutely. So you'll see in terms of the slide deck, so there'll be examples where only quality is improved, but no mortality effects are included, or only mortality effects are included, but no quality of life gains are included. But yeah. It's and we see that. In fact, we probably see that a lot in end-of-life oncology therapies, where they will be increasing quality of life, increasing the length of life by, say, 6 or 7 months at the end, but the quality of life will be essentially the same. So we see that frequently in oncology end-of-life therapies.
I've got another online
Great.
question. So this is about how to evaluate whether it's possible to go to market without the third-party payer, i.e. NHS reimbursement. So procedure for national reimbursement is complicated, time-consuming and costly. Is there a way to evaluate if it's even worth going through it, whereas perhaps a patient is willing to pay some price for the device drug out of their pocket?
Yeah, it's a complicated question, interesting one. Could you ask the individual if they're UK focused or...
She's based in France.
Based in France, okay,
Yeah.
Which is even more complicated in terms of medical devices, in terms of... Okay, so if I give... I'm going to say in the majority of cases, Health Authority Santé will not evaluate drug devices in the majority of cases. So the work that I've done in France has all been pharmaceuticals, and I think all of their guidelines have only referenced pharmaceutical technologies. I think it's slightly different. So if I could say that there are going to be instances when national or regional level decision making is not appropriate for your device, right? And that's still the case here in the UK. It's becoming less rare. So there are established guidelines for the National Institute for Health and Care Excellence, NICE, for selecting in medical technologies in for evaluation, and they have specific frameworks for that. But not 100% of new medical technologies are evaluated by NICE, so they don't necessarily need to demonstrate cost effectiveness or budget impact. In which case, then it becomes down to local procurement. And again, the extent to which health economics informs local procurement strategies then will, I would say, be on a device-by-device strategy. So we do know that the major companies operating in this area, so Abbott, for example, or Boston Scientific, will include a health economics analysis in terms of any of their submissions, but they have the size and capacity in the departments in order to be able to do that. I would say for some companies, some smaller companies, the extent to which you'll need to understand or provide evidence for will vary based on the nature of your device, and it may not be necessary. But whether it is an added advantage or not, you want to consider that. I would say at least you want to consider what the potential costs and effects are, even if you don't submit any of that evidence base.
My device is going to be direct to customer.
Yeah.
Confident that it will, as one always is, confident that it will sell well on a smaller scale.
Yeah.
You're doing that. You'll create some evidence based off that. But is there then a danger to take it, for example, into the NHS? If they're seeing all this benefit to their numbers by an external party paying, how do you then translate that across to say, well, if you guys pay and take it to a broader market, again, or do they then look at what you've already created as their free value added?
So they're probably going to ignore it a lot. So, and if I could put an example around your case, so home genetic testing, for example.
Yeah.
So what we've seen is a lot of individuals are purchasing these home genetic tests to evaluate their risks of potential diseases. Then what they're doing is, so they'll spend their 100 quid, 150 quid, then they'll go into their GP and they'll present their GP with these results. So this is my home care test. Well, I'm going to have all of these diseases, or what the implications are. Essentially, what that GP will do, they'll dismiss that test and they'll just consider that irrelevant, and they'll just, and then essentially if there are any true risks, then it'll be the NHS will pick up their genetic testing route, for example. So what you see is a lot of the time for these external third-party tests is that they're essentially ignored by the NHS. But let's say, for example, that you had established a market that was resulting in benefits for the NHS, for example. Then, and say, for example, so it could be some monitoring device or something like that. Then there would be arguments to say that if that's substantial enough, then the NHS might be really interested in expanding these. And what we've seen that happen is done on a local basis. So CCGs have taken up these technologies and then they've said, okay, this could potentially, in terms of reduce costs or improve quality of life. In which case, what we've seen the NHS do a lot is they've taken companies and they said, okay, you may not have the evidence base, but it looks like it's really good. Let's do a pilot program and to develop an evidence base around that to see if it does generate benefits for the healthcare system. But again, it really comes down to the innovative nature of your device. Like, is it truly, does it truly have implications for the NHS, or are these just individual ones at the end?
It's in asthma.
Yeah.
It's, if we made the 5% impact that we thought, we're fairly sure we could,
Yeah.
you know, we'd save 70 million to the NHS.
Well, exactly.
5 years. And that's a very sort of lower based guess on what we've seen. We need bigger numbers, obviously.
Sure.
But
and there would be an argument to say, so why would so there would be nothing to stop you making arguments so that should be funded by the NHS if there are savings in the NHS. Whether they take up the evaluation or not is a different question. So that will depend on many other different types of factors. So what they may say is, for example, NICE will say, oh, we don't want to evaluate your technology, we don't have capacity, or there's not the evidence base, but you can still go through procurement routes for the NHS if you want. It's always an advantage to have a national level evaluation for technologies, because essentially that gets over some of the hurdles, particularly the early stage hurdles in terms of proving your evidence base if it's been evaluated externally.
I mean, the evidence base, I suppose, on my device aligns with some of their longer term goals of the societal factors.
Yeah.
So it would seem on point with some of their longer term goals.
Sure.
So would that then fall more into their bracket
Could do.
rather than saying here's an A versus B? There isn't really a B option at the moment.
Yeah, could do. Yeah. But it's very individual at that basis and there's not a clear-cut rule in terms of the evaluation. Yeah. There is, what you might be interested in is there's a new stream in NICE for medical devices, medical technologies, and they provide advice to SMEs, which I think is cheap or free, and in some cases that results in an early stage evaluation of your technology in terms of what you should do for developing an economic evaluation or evidence base, and it will also point you in terms of routes. That might be, so I'll send the link on. I'll also make that available online. Yeah.
I have an online question. That's
Yeah,
okay?
go for it.
So the question's around what improvements might be seen in the access to data to support these types of assessment. So how much of this is still dependent on published literature, or with improvements in gathering data, is there a possibility for this coming from healthcare providers? Where do we look, and how might this be obtained?
Yeah, so if I just summarize the question, right, so this is where does the data come from? Does it all have to be provided by the company? Can it come from literature? Can it come from external data sources? Most evaluations will have several sources, so that will include literature, it'll include a primary evidence base for your technology. You'll need to have a primary evidence base for your technology. You need to demonstrate that it works. And in terms of the economic modeling, so typically what we do is we take all of that evidence and then we can extrapolate that for example, long-term effects. So, for example, if you don't have data on quality of life or mortality, that's not to say that we can't model those or take them from different sources and apply them into your, in terms of an economic model. So essentially, this is an exercise in evidence synthesis from multiple sources. I have not seen situations where data is provided by payers, for example, but that's not to say that that's not the case. So it could be that there are some payers that are sitting on some data and they may want to say, okay, given your technology, this is the data that we have. Is there something that you could use this for in terms of it? I've not come across that, but that's not to say that that's not the case. It is one of the most highly rated challenges or recognized challenges for medical device companies is the generation of data beyond the efficacy of your device. I would say that it'll be on a case by case basis in terms of what the requirements could be. to generate additional data or use additional data sources. Any other questions? Yeah, go for it.
So, obviously, as a device developer or manufacturer, you think your device is the best thing since sliced bread. That gives you a tendency maybe to overstate the benefits and underestimate the costs. So,
yep.
Having an independent health economist take that away and do it independently, I'm just wondering how much credence or value does the NHS give to independent health economists? Do they actually take it at face value, any report that shows, positive health
yep.
economic impact?
Yeah. Increasingly. So we see that. So for example, locally here you have the Academic Health Science Network. I can't remember the acronym. They frequently are asked to commission. So they'll frequently commission consultancies to conduct those independently. I think the source of funding will be important for the NHS to understand. So for example, if a company was to provide an unrestricted research grant to a consultancy to develop what would be considered a truly independent evidence base, then that would weight highly. But I have seen submissions based on so for example, if small companies have come to us and said, can you put together a dossier, for example, a value for money dossier, and then we see that a lot of these agencies are increasingly capable of understanding these and critiquing them, even if they are industry funded. There is a program, again, I mentioned the program at NICE, where there are there's a specific framework for SMEs, and it's a very short evaluation. So I think that program is maybe less than 2 years old. So I haven't seen what the impacts are in terms of reimbursement in terms of the NHS. But I guess what that will be used as a vehicle for local hospitals to be able to evaluate. So, for example, NICE will have a 2-page summary on your device, and that'll outline certainly the efficacy and the potential costs. We'll also have some of the limitations, and then that's used as kind of a barrier kind of destroyer for some of the early reimbursement hurdles for the NHS. In terms of across Europe, this is again a challenge. So I think it's fair to say that the evaluation of medical devices is varied. And we have seen that even for pharmaceutical companies, for some of the Eastern European countries in Europe, they're really playing catch up in terms of evaluating pharma technologies. So that means that they're well behind in terms of medical devices. So for some of the Eastern European countries, we probably wouldn't expect capacity for decision makers to evaluate these types of reports for medical devices. So you can see there's extremes across Europe.
I suppose my question is sort of related to that. As a simple or straightforward devices person, is it possible to work out the qualities for your own product, or is it better to go to a health?
Could try. It depends. So if you're a device company that's doing trials, for example, as in like randomized controlled trials, then you should be collecting quality of life data from the patients that you're recruiting. If you are not, then from an economics point of view, your trial is not worth as much as what it would be to administer a 2-page survey to your patients as they are. That would be in the context of a lot of RCTs for medical devices aren't necessarily, so they're measuring sensitivity, specificity, those type of things, not necessarily measuring the downstream effects potentially. So you're saying the device has a specific sensitivity, has a specific specificity, and this is where I get to. So this is my evidence, and it's better than my competitors. In that case, what you would use is the evidence base for the literature in terms of quality of life to say, okay, so given the performance metrics of my device, I plug this into this economic model, and then I can estimate what the difference will be in qualities. So in that case, you potentially, you will be using outside external data sources. In terms of measuring them yourself, in terms of gathering and calculating them yourselves, why not try? But in most cases, I would say consult a health economist. And I would say that because I'm a private industry health economist who's trying to generate money for my company. So you can take that with critique.
Right, hi Ian. Thanks so much for that. It's been really, really insightful. Can you just click forward to your contact details?
Of course.
Because I'm sure there'll be further questions when we all leave here. you know, and if people could, you know, address them to you as the expert, that would be really useful.
No problem. I don't have my, that's probably on the first slide.
In fact, if you Google Ian Jacob and health economics outcomes research, you should find that. But I'll be able to forward the address. So I'm sorry about that. Yeah.
Okay. Right. Well, thanks everybody for coming on today. It's been really useful. Thanks also to our online audience. Hope we've answered most of your questions on there. There will be further webinars as this project progresses, which we'll send out as they become available. So thanks to everyone for participating today. It's really appreciated. Thank you.